on what's available now. Later on, could you have sort of boutique therapies for people who want to wean off their steroids and so forth? Maybe. But what we really need to focus on is people who don't get better with their inhaled corticosteroids or their systemic therapy. And so these are some of the ideas. Some of them I've gone over with you. And actually, the reality is that the list probably goes to the floor. There's many, as you see, so many different determinants of asthma phenotype. So to summarize what I've taught you, not taught you, but discussed with you, Severe Asthma Research Program, it has taught us that bronchoscopy can be safe in severe asthma, and asthma is heterogeneous. Asthma affects a large heterogeneous population worldwide, and the acetaminophen use patterns could help to explain this phenomenon. Severe asthma heterogeneity makes it poorly suited, in my view, to unbiased analysis. Medical biased model will be the best for managing severe asthma in the long run. That's my conviction. And the phenotype with high GSNO reductase activity is an example of how this medical model might work, with recognizing the phenotype, making the diagnosis based on inhaled GSNO, and treating in a very targeted way a specific subpopulation and not everybody. And so I'll just acknowledge the people that helped substantially with the data that I've shown you, and then take some questions. Jason Morosky in particular, and Jerry Teague in the SARP, a variety of people who've helped at UVA, Ann Fitzpatrick at Emory, Serpo and Susie, of course, in Cleveland Clinic. I showed you some data from our collaboration with UNC and with UC Irvine, and Jonathan, my old friend who I met in this building. Oh, sorry. Sorry about that. I thought I turned that off. And that's it. That was not my timer. That's actually somebody calling me. So. All right. Thanks very much. I'll be happy to take calls.
Thank you very much. Jonathan Stamler, former pulmonary fellow at the Brigham and Women's Hospital.
And cardiology fellow.
And cardiology fellow, right.
Right.
Well, thank you very much for an innovative, well-argued discussion. We open it up for questions, if you would. I'm going to ask, as a naive member of the audience, is there a GSNO reductase inhibitor out there, and can it be inhaled?
There's several. One of them can't even be dissolved very well, so it makes it difficult to use. But that would be a great question for your chief of medicine.
Uh-huh. Okay.
I'll just leave it at that. Yes?
In terms of tissue remodeling in severe asthma, GSNO, any data on cell death, proliferation, so effects on GSNO?
Yeah, so GSNO does favor apoptosis of eosinophils. We don't have strong evidence that it causes any other sort of remodeling effects of the basement membrane. If you look at the GSNO reductase deficient mouse, it is histologically protected from some aspects of severe asthma, but still mounts an IgE response. So it's not completely immunologically protected, and has some histologic features of asthma, despite not having the methacholine response. Yes, Les.
Any data about acetaminophen during pregnancy?
Great question. I don't think they asked that specifically. So, interestingly, though, the Ethiopian cohort and Berbier took 1,000 pregnant women and said, right from birth, what are you doing? And who's going to develop asthma? So there were lots of neonatal data about acetaminophen, but not prenatal data that I'm aware of. Yeah. Yes, Ike.
I like your concept that the clusters that we should be searching out are more pathophysiologic clusters and biochemical clusters.
Thank you.
That's been sort of the way I think we should be approaching it. Then you can targeted therapies for different clusters on that basis. Why do you think that the phenotypic clusters, Wendy Moore's clusters, have gained traction in any way?
Great question. So first off, I want to say that Wendy has done more work in the SART than any other human being involved with the program. She does a fantastic job. She did the bronchoscopy paper that I showed you, and I think that those clusters, the unbiased mathematical clusters, are informative with regard to asthma heterogeneity, and there's a possibility that some of them will be relevant to pathophysiology. I just wouldn't put all my chips on that number. I don't think. That's my argument, is that shouldn't be our focus. It's caught people's interest in pharma because I think they're realizing that asthma is heterogeneous, and that's a nice way of looking at it. Philosophically, it's nice to go at an unbiased approach. That was the approach that's the approach that people have used for genomics, right? So unbiased approach looking for a gene. And sometimes it works, but I think in this case it's not as informative. Unbiased approach looking for a phenotype. Sometimes it might work, but in this case I just don't think it's, it's an interesting mathematical exercise, and it alerts people to the heterogeneity of asthma, but I don't think it's going to be therapeutically informative. Yes, sir.
Ben, that was a really beautiful talk, and I just want to be sure that I didn't miss it. Is there some relationship between acetaminophen and GSNOR?
No. I just thought of controversial things I could say. And they both happen to be. No, the only relationship is that I think acetaminophen, in my worldview, helps to explain why so many different populations might have asthma, with so many different genetic backgrounds. And one of those that is more in some populations, like you saw in the Hispanic population than in other populations, is GSNO reductase. So you don't want to treat everybody with GSNO or with an inhibitor. And how did all these different kinds of people wind up with asthma? GSNO reductase doesn't explain asthma or severe asthma genetically, biochemically, or anything. But when you do find that person, that's who you want to treat, whatever caused their asthma. Right. That was my take on it. Right.
Well, thank you very much again for a terrific presentation.
Well,
Very much enjoyed having you.
Well, thanks so much for having me, Chris. That's great. It's great to be back.